Good afternoon, everybody. My name is Jen Monahan, and I am a partner with Health One Technologies. We are here today to present to you the changes for 2013 Stage 1. The changes that we discussed today will not be Stage 2 changes, but only changes affected by Stage 1. Before we actually start with the webinar, I would just like to take care of a couple of items. We are going to hold all questions until the end of the webinar. If you have a question, you can actually put that into your chat window on the GoToWebinar, and we will address those at the end of the webinar presentation. The webinar will also be recorded, and at the end of the webinar, we'll email everybody a link out to that so that you can review it at any time that you would like. Before we get started, I would like to just talk a little bit about Health One Technologies and what we do. We are a company specializing in the implementation and maintenance of GE Centricity. We do work with other vendors as well, but our core focus is GE Centricity. And to date, we have assisted about 500 plus providers in their attestation with meaningful use. And that means that we do things like change form components and help develop custom reports that they need, address workflows, complete any training requirements, and also help with meaningful use dashboards. Presenting along with me today is Tanya Martin. She is our COO and also our in-house meaningful use expert. We're going to present the session with covering, first of all, the things that are more clinical workflow impact, and then we will get into some of the measures that are less of a clinical impact but still required for meaningful use. So to start, I'm going to give an overview of what we're going to talk about. The things that we are going to cover today are for the Medicare incentive for eligible professionals only. We are not going to cover the hospital perspective. And what we're talking about are the measures that CMS has made modifications to for 2013. They've also removed a few measures as well. So we're going to review the things that are modified in this particular attestation period. Again, this will not cover Stage 2. It will be changes to Stage 1. So we're going to just review quickly the meaningful use stages. We're going to talk about some dates to remember, the dollars that are associated with these, and then we're going to actually get into the menu items and the core items themselves. So just to recap the meaningful use stages, I'm sure everybody has seen this spreadsheet at some point in time. What it is basically which year you're doing your attestation in. So if you look at the red arrow, we are in the 2013 column. Now, many of you may be in your full year of attestation at this point. So if you attested for 90 days in 2012, for instance, you have a calendar year attestation in 2013. And then some of you may also be in your original 90-day attestation for 2013. So the things that we are going to cover today basically encompass both of those, whether you're in a 90-day or a calendar year. Some dates to remember. On January 1st, 2013, these changes took effect for Stage 1. There are also some hospital changes, but we are not going to cover those today. If you are attesting for your 90-day, in 2013, October 3rd is the last day to start your attestation period, so you're really down to the wire at this point. December 31st will be your end of reporting period, and then everybody has to be attested by February 28th of 2014. So that's the last day to complete your actual attestation. I also put a little note at the bottom of this screen to let everybody know, if you're not already aware, that effective this year due to the sequester cuts, there is a 2% reduction to your Medicare EHR incentive payments. So anybody that started reporting on or after April 1st, your total dollar amount will be decreased by 2% because of the sequester. So the incentive payments, again, for anybody that started attestation in 2011 or 2012, you actually get your total $44,000. For those of you that are reporting your first year in 2013, that number has decreased. So instead of getting your $18,000 for your stage 1 attestation, you're actually going to get $15,000. And then in 2014, that number decreases a little bit more. So we're going to get into what the changes are now for 2013. The first thing I want to talk about is the CPOE measure. So this is core item number 1. In the stage 1 measure previously, the way that this measure worked is that you had to have 30% of unique patients that you entered a medication, that you prescribed a medication on, whether or not you actually ordered that medication. So if the patient had a medication on their list, that counted in their denominator. What they've done in 2013 is they've given us the option to actually report only those patients that have a medication ordered by the EP in the denominator. So this in particular is going to affect specialists. This was definitely a troublesome area for specialty providers. It will allow us to only count those patients that we're really responsible for the medications on. So regardless, in the previous years of attestation, regardless of whether or not you actually prescribed that medication, if you were doing the job that you're supposed to be doing and keeping your med list up to date and active, that patient was counted in their denominator. So for 2013, now what we do is if the patient actually had that medication prescribed by the provider, they're counted in the denominator. So if the patient has a list of medications but you didn't order them, they will not be counted in the denominator. So the key word here is ordered or prescribed, which is the change to the denominator impact of this measure. In GE Centricity, they actually have 3 reports that we can run to measure this item. These reports were there previously, but the CMS rule changed in 2013. This is just a little workflow because this particular measure is very confusing and can definitely be something that's difficult to understand. So what we've done here is outlined for you the process of running these reports. So what happens first is everybody should run the CPOE for Med Orders report. That's the first report that's going to be there. In that, if the EP is compliant, then you don't need to do anything else except monitor that report. You're going to monitor it, make sure that your providers are continuing to meet their 30% threshold, but you don't need to actually do anything further from a reporting perspective. If the provider is not over the 30% threshold, then you are going to run the CPOE for Orders Qualification Report. That report is going to tell us if the provider qualifies to run the third report. And by the qualification, what it looks at is it looks at did the provider prescribe over 100 prescriptions in that reporting period, and are they less than 30% of the threshold? So if they meet that requirement, then they're eligible to run the third report. If the provider shows up as not qualified on the qualification report, a couple of things will need to happen. A, you either need to go back and complete a workflow review to determine what's the provider doing that's not correct. It could also be that that provider is eligible to exclude from that measure because they have written fewer than 100 prescriptions. If they do qualify, then you are going to run the CPOE for Med Orders Prescribed Medication Report. That report is then going to allow us to say, okay, if they're over 30%, they're compliant. Again, we just need to monitor the actual reporting from whatever time we are attesting to make sure they continue to be over 30%. If they are not at the 30% mark, then we need to, again, either review the workflow or determine if they can be excluded from that measure. I would make the assumption that anybody that is in their calendar year reporting period, I would assume that most providers are writing over 100 prescriptions. There may be some exceptions to that, but I think in general, that's going to be a difficult measure to exclude from if you're in your calendar year reporting. So what sort of workflow things do we look at when we're talking about the CPOE measure if our providers are not meeting it? First thing we're going to do is make sure our system is set up correctly. So our licensed users signing the medication orders. So the first thing you want to do is look at your job titles in Centricity and make sure they have certain words in them, because this is how GE looks at their reports. The other thing you want to do is make sure that your front desk and MAs in the office are not signing the prescription, because if they are, they don't count as a licensed provider, and that does not count in the numerator of this reporting structure. One of the other things we find is providers have a tendency to hide prescription pads in their offices, in their exam rooms, and they kind of handwrite prescriptions. So that is another area that we focus on when we're working with clinics. Just get rid of those prescription pads in any way, shape, or form. And then prescribing methods, just make sure that we're not using handwritten samples or historical, because those do not count in the denominator of ordering a medication. And then again, did your provider write fewer than 100 prescriptions? If they did, they can exclude from this measure completely. So the next change that I want to talk about are the vital signs, which is core number 8. This particular measure is, I think, very exciting as meaningful use can be, because it does allow us some flexibility in excluding from vital signs. There are changes to the measure itself and exclusions with this, so I'm going to break this into 2 parts, and we're going to cover first just the measure itself and the slight changes that are in that, and then we'll talk about the exclusions. So in stage 1 previous years, up until 2013, we had to record height, weight, blood pressure. We had to calculate BMI, and we had to plot our growth charts. If you look at the last line here, so we had to do that for 50% of patients, and it was ages 2 and over. So what they changed in 2013 is the measure itself stayed the same. So the change, we still have to do height, weight, blood pressure, and all of those things. But what they've changed is the year. So now we have to do blood pressures for patients 3 and over, and height and weight for all ages. So they just made that slight change to the actual measure, which is an option for 2013. We can select as an option that we're going to report that, but in 2014 that requirement will actually, that it will change, and that's the way the measure will actually read at that point forward. So that is just a very slight change, but if we have any family practice physicians or folks that are seeing a lot of pediatric patients, that does impact you. So this is the bigger change, the exclusions that we can choose for vital signs. So last year and in 2011 as well, we had to either do all of those, height, weight, blood pressure, BMI, or we had to say that none of those vital signs were specific to our scope of practice, which to me was always a sort of risky exclusion, because can you really exclude that all of those are not relevant to the practice that you have? So we had always encouraged providers to really think hard about excluding themselves from that measure, because almost everybody needs a blood pressure or they need a weight for their practice. So what they did in 2013 is they changed how we can exclude from this. So the first one is, if you see no patients that are 3 years or older, you can exclude from blood pressure. So I think that one doesn't impact the majority of our clients that are doing Medicare initiatives. The other thing that we can do is, just like we did last year, we can believe that all 3 vital signs, height, weight, blood pressure, have no relevance to our scope of practice. So if you decide that really your practice never needs to do any of those things, then you can just exclude yourself just like you did last year. This is the bigger change. So if we feel like height and weight are relevant to the practice, but we never do a blood pressure, we can exclude ourselves just from the blood pressure measure. Or if we believe that blood pressure is relevant, but we don't really care about height and weight, it's not something that we do on a regular basis, then we can exclude ourselves from the height and weight measure. So for, again, 2013, this is an optional choice that you will have. So when you do your attestation, you will have a window that will give you the ability to exclude from these. In 2014, this will be a change permanently to this measure for stage 1. Okay, I am now going to hand this over to Tanya Martin, who is going to talk about a few of the measures that are less specific to the clinical workflow and just more of regulatory measures. So Tanya, go ahead.
Good afternoon, everybody. The first one that I would like to talk about is the electronic prescribing. So the e-prescribing core 4 measure, there was an exclusion that was added, and this may not be relevant to everybody. So any EP who does not have a pharmacy within their organization, and there are no pharmacies that accept electronic prescriptions within 10 miles of the practice location at the start of the reporting period, can file for that exclusion. I know that one was really exciting. The next one is the menu exclusions. And this can be a little bit confusing for some people. So starting in 2014, you are no longer allowed to attest with an exclusion to any of the menu measures if you're able to meet other menu measures. So in other words, you can't select a menu measure to exclude yourself from and still be able to meet some of the other menu measures, and that's across the board. I know we're not going to talk about the CAHs and the eligible hospitals today, but it does apply to the EPs as well. And again, that's in the menu exclusions. The next topic that we will go into is the electronic exchange of the key clinical information. This was Core 14, and this is 2013 and onward, and it is a requirement. So the objective for the electronic exchange of the clinical information will no longer be required for stage 1. And the reason why is some of the providers were faced with numerous challenges in understanding the requirement. So moving forward, instead, they are going to create a more robust requirement for the exchange of clinical information. And this will be part of stage 2. Where you'll be allowed to provide a summary of care record for transitions and referrals. But again, we're going to stick with just the change, and the change is just that this Core 14 is no longer going to be required for stage 1. So moving in the same direction, the e-copy and the e-access stage 1 will be replaced beginning in 2014. So the original measures, which was the Core 12, and the providers, that was the one where the providers were providing an electronic copy of health information for diagnostic tests and problem list, meds, allergies, the discharge summary upon a patient's request, or the e-access, which was menu 5, where they were providing patients with timely electronic access to their medical information within 4 business days. Those 2 measures are going to change in stage 1. And that change is going to include both of those measures being brought into one measure. And that is going to be that that you provide patients with the ability to view online or download or transmit their health information within 4 business days of it being available to the EP. And that's at a 50%. So really what they're looking at is driving people towards that portal. And this is an important measure because, again, it's required starting in 2014, and we would really like to open the discussion up further down the line as to where we can provide assistance with portals and talk about portals. So we'll probably have a whole webinar series, webinar on portals and what that means and what that looks like for practices. So our next measure is the public health reporting measure, everyone's favorite. In stage 1, so in 2013 onward, it's going to be required for immunization registries, syndromic, and lab results that the provider perform at least one test to send that data to the public health agency, and that's obviously where it's prohibited. So in our experience in the last few years, it's kind of been all over the board, depending on the state that you live in, whether the requirements are meeting your vendor requirements. So if the state requirements for the registries or the public health places where they're accepting the data are matching what the vendor requirements are, then you're not going to meet that, that exception anymore. However, we still look at this as a measure that has to be tested, and we did get some questions just recently whether if the test fails, will it be accepted? And the answer to that is no. So it has to be an accepted test. The test has to continue to actually meet the requirements of the vendor and of the agency. At this point, this concludes our webinar. We did have a question that came through, and it was if the slide deck would be made available, and the answer to that is yes, we will make the slide deck available. The webinar is being recorded. You will also get a link to the recorded webinar, and at that point you can actually pull the slide deck from there as well. Again, our contact information is listed here, Jen Monahan and Tanya Martin. Our next webinar will be made available on October 30th at 12 o'clock, and we're going to talk about preparing for the 2013 attestation and the initial stage 2 planning.
Tanya, I'd just also like to add to the group that, again, this is the changes for stage 1, year 2013. And if any of you are in your first year at testing or even in your subsequent years and need any assistance with the process, we are certainly more than happy to help you get through that process. We are hoping that as we continue these webinar series, we will get into more details with both the attestation process itself and also in helping everybody with their stage 2 planning, as that is quickly coming upon us. As we get more information regards to CPS 12 or EMR 9.8, we will certainly be holding webinars and how we feel those changes would be best implemented into a practice. So, okay, do we have any more questions at this point in time? Oh, here we go.
So,
okay.
One question actually came through. Do you need to do all 3 of the public health measures? And the answer to that is no. You do not need to do all 3. You need to do 1. So either immunization based on your practice, based on your specialty, immunization, syndromic, or labs.
Another question came up. It says, we do not have the latest GE report that includes these changes. What would be the possible impact at the time of attestation? So when we install the GE report, whether you're on the latest version or not, those reports will go back and retrieve that data as required from the system. So the data itself is being collected. The reports, once you install them, will modify the data reflected to you. So there should not be an impact if you are behind in your latest installation for the reports. Another question came up. It says, for the state immunization registry, if you submit a test and it fails, does that meet the measure in 2013? And will the test change be in 2014? Tanya, can you actually answer that one?
I can. So a failed test is not a test. It actually has to pass according to CMS. And then the second part of that, will the test change be in 2014? So the requirement, yes, it will be in 2014.
Okay, and then we have one more question. Can we claim an exception to the mass immunization registry since we are required to have an interface to send data from the EMR 9.5? So I'm assuming that that interface is sending the data to the immunization registry. If not, you can follow up with me directly on that. But if that interface is in place, that is essentially your submission to the immunization registry. And if I'm reading that question wrong, please certainly feel free to contact me directly, and we can talk about it further. But that's what I'm seeing here.
And there are also in the state of Massachusetts 2 ways to suffice that immunization registry, and one of them is through their web portal directly or manually, and the other is through a direct connect from your EMR.
Okay, we have a few more questions here. Let me see.
There's one other question I'm seeing here, and it says, can access to the portal be used as a visit summary? And since the same information is in both places, it's interesting. Yes, it can. However, in our experience with some portals, it actually gives a lot more information than just the visit summary. So I think that is really up to what the providers want to send. The scope of what the summary is, according to CMS, is a little bit broader than what we've seen a portal be able to offer.
The other thing I will add to that to sort of put into perspective is GE's reports, if you are using the portal, will not reflect that summary information. So the standard reports that are out of the system will not. You may have to work with your portal vendor or perhaps use something custom internally if you have a workflow that says you send it up to the portal, something along those lines that you will actually need to get your numerator from, because the GE reports will not reflect that. We do have some practices that utilize the cryptic automatic clinical messenger tool. I'm not sure if you all are familiar with that or not, but it allows you to sort of automatically send a message to your patient securely. So you could, in theory, continue to use your GE clinical visit summary out of the system as a patient letter or a handout, and you could send that automatically via your secure messaging tool to the patient, and that will count then, and it will show up in your GE reports. But if you are using the portal itself, it won't actually be available on the report perspective. I have another question. Do the GE reports reflect these changes? So the answer is yes and no, I suppose. Most of the changes that we are talking about are when you actually complete the attestation itself. The exception to that is the CPOE measure, and GE does have available the 3 reports for the CPOE measure. So as I showed in the slide deck with the workflow, you'll actually be able to see all of those reports in your system. And then you can choose which one of those you run at that point in time. Are these changes applicable to Medicare and Medicaid attestations? Tanya, do you know the answer to that question?
So some of them are applicable to both. The presentation for today, we were really delving into Medicare and not Medicaid. If you have specific questions regarding Medicaid, you can submit them to us directly, and we can answer them as we get them in.
Okay.
Next question was in regards to surveillance. If the state cannot accept, can we apply for an exemption? And the answer to that is yes. It still falls under your state availability.
For the CPOE measure, which report do you use when attesting? That depends on what your findings are when you run these reports. So if you run the initial report, I think it's prescribed or ordered medications report. I think I have it listed in my slide deck. If you run the medication orders report, if you are less than 30% on that, then you can run the qualification report. If you're qualified, you can use the medication orders prescribed medications. That final report, if you are over 30%, that's the one you're going to attest with. However, if on the initial report you're over 30%, you're just going to report with that one. You don't need to do anything else. I hope that made sense. That particular report process is very, very confusing and cumbersome. But if you need any further assistance, feel free to contact us, and we can help you work through that as much as we can. One more question, Tanya, so to clarify, is an immunization registry failed test acceptable for 2013 stage 1 attestation?
No, if it's failed, it is not. The intent of this is to continue sending the data to these agencies. I do actually have a ticket number that I have open with CMS because this was a question from one of our clients. And if you're interested, I could send you that ticket number and you can track this information as we discuss it with CMS.
If the lab I'm using reports the patient results to the state now through their system, do I have to submit it again through GE to make the measure? I honestly don't know that we know the answer to that particular question. I think we could certainly do some research on it. I want to say yes, because the lab is not within your entity, your certified product. But I think that is something we would have to research. So whoever asked that question, if you do want to contact us, we can open up a case with CMS and follow up for you. In regards to ambulatory measures, do we have to be actually reporting to the National Quality Forum, or do we just report the figures from our EMR reports? So this is going to change quite significantly in 2014. For 2013, we can just use our EMR reports, report them just as we have in previous years. So in 2011, 2012, we were able to just choose our quality reports from the structure, the CMS structure, run the reports out of the EMR, and submit those. We should be able to do that. We will be able to do the same thing in 2013. However, in 2014, that process is going to change quite significantly, and Tanya and I will be sure to do a follow-up webinar with that particular process because it is going to be much more confusing. The other thing to add to that is if you are doing PQRS reporting electronically to CMS right now, you may not have to report your reports from the EMR. So there's an option if you're doing PQRS that you don't necessarily have to run them out of Centricity as well. So that could be another avenue that you want to look at if you're already doing that type of reporting out of MQuick or another registry. please clarify, is a successful test of public health reporting required in 2013 in addition to 2014?
Yes. Yes, the success of the test it begins in 2013, required in 2014.
And Tanya, just to clarify on that, if the state does not have something available or it does not meet GE's requirements, they do not have to do the test, correct?
That is correct.
So in
most cases, in most states, not all, a lot of states, their agency's version of HL7 does not match the GE version of HL7. Therefore, you cannot submit the test. We do have states that we work with that actually have the setup, the correct setup, and the correct version to accept the test. But in the majority of what we have seen, most states are not ready yet. And we continuously track, I think, 7 states, most of the New England states and some outside of New England, on a quarterly basis. We are working with their agencies to make sure that we are abreast of where they are in the process and if they are ready to accept the test. And what version they're on and what version they will accept. So we continuously monitor that process.
Yeah, I didn't want the audience to be concerned that, if your state's not ready, you don't have to do that test. But if your state is ready, you have to do a test, and it has to be successful. It can't be a failed test. When are the reports going to be able to count educational handouts other than medications? I'm sorry, I have to laugh at that one because it's one of my pet peeves, and I completely wish I could give you an answer to that. So currently within GE, anybody that is doing meaningful use attestation, they know that in order for us to do patient education, the only option we have is to do it within the medication window itself, and to check the box that says, I gave this patient medication instructions, which is completely ridiculous in my mind. But regardless, that is the way the system is set up. I will say that we have had a few practices develop that the core measure behind that particular, if you read the CMS requirements, is actually that the system prompts you to provide that education. So, the way that GE built this in was that's the only area that the system technically prompts you to give education based on a medication or a problem that patient is on. I will say in CPS 12, I believe that is going to change quite significantly. So for next year, this should be a much better issue for us to handle. We have had a few organizations develop custom forms around the system prompting education, and therefore, being able to allow for this measure, but it did require custom forms and custom reports to be developed. So it's just an area that it will be coming with later versions of GE, but as it stands right now, it's just not available. That's the workflow that we have to do. Let me see. Does the immunization registry failed test apply to Medicaid attestations?
I actually do not know the answer to that question. That is something I would need to research.
Okay. And then we have one. Our state, New Hampshire, does not yet have an immunization registry. So if there is no immunization registry available, you should be able to exclude from that particular measure.
You absolutely do exclude yourself from that measure.
Yeah. Does sending a secure email to the Bureau of Health satisfy the measure for surveillance in lieu of an interface?
Unfortunately, no.
Yeah, I didn't think so. It has to be in the structured format so that it can be reported down the road.
Right.
We are reporting PQRS measure through claims for our 5 physicians. Can this still be done this way in 2013? If you are doing PQRS measures, which is a little separate from meaningful use, if you are submitting them via claims, you can continue to do that. The rules did change a little bit in 2013, though. I think it has to be over 50% of your patients, so hopefully you have been doing that process from the beginning of the year. There will be some changes to that moving forward, and I also believe that if you are using the clinical quality measures for meaningful use, if you're trying to use your PQRS for that, I believe they have to be submitted electronically, like through MQuick or a registry of some kind. I don't think the claims submission actually meets that measure. So you would actually have to still do your quality reports out of GE for that. Can you utilize a skip year with Medicare as an AP? Tanya, do you know the answer to that one?
I'm assuming a skip year means you attested in 2012, you're not ready to do or cannot meet an attestation in 2013, so you're skipping that year, and then moving on next year you would attest again. And the answer is yes. You do not get that money, obviously, but you can skip a year.
Okay. For the patient education report, somebody has the same pet peeve that I do. Couldn't you just revert back to the old report so that it's capturing all education and not just the med handouts? So the answer to that would be technically, yes, you could. However, that original report, and only the folks that have been attesting since 2011 and forward probably even know this, the original report that GE did release did just look at patient education handouts if you printed a handout at all. The problem with doing that is it does not really meet the regulation. If you read the CMS documentation, the way that that original report was written does not necessarily meet that requirement, because you can print, as a provider or a staff person, you go into the system and you can print a handout on whatever disease you want or whatever medication you want, but the system is not prompting you to do that, and that is actually the CMS requirement for patient education. The system has to prompt you to do that. So while technically, yes, you can revert back, that report is really not compliant with the measure. Okay, so I think that may be the end of our questions. I'll keep this line open for another minute or two and see if we have anything else that comes in. Okay. Well, I think that wraps us up for today. Hopefully we will see you all or virtually see you all on the 30th. At that point in time, like I said, we will be planning, helping everybody plan their 2013 attestation, and with any luck, we'll have some more information about CPS 12 and be able to start breaking down how to plan for stage 2. So thank you all for attending, and we look forward to hearing from you soon.